फर्क पड़ेगा because polyclonal response होने वाला है. So ultimately it is only the live vaccine because of an immunosuppression which it gets induced after various monoclonal immunity. So I am very sure about this statement I am taking. हाँ हरी अलग बात है, अगर देना चाहो तो inactivated vaccine after 2 weeks, that's steroids and tocilizumab, and any live vaccine depending upon monoclonal antibodies. The product is well used. For tocilizumab, it is 3 months.
3 months.
I think the better question could have been flu. We are having a lot of flu these days, and you want to cover against flu, and such a patient should not get flu. And then in that situation, yes, and go ahead and give it. Even if there is a immunogenicity is bit affected, I'll give it.
So whatever literature,
there's a hurry for flu, but no hurry for HPV.
So whatever literature I could find, they say that live vaccine is not certain, and students are vaccinated after 3 months of therapy, and rituximab should be after 6 months.
So therefore, very statement for tocilizumab it is 3 months. For TU is 2 months. So this is one thing which is acting against the tumor, the rituximab. TU का वो मैं दोबारा पढ़ाऊंगा. इनमें immunosuppression ज़्यादा होती है. तो कैंसर थेरेपेटिक्स में मेरी मोनोक्लोनल यूज.
Sir, you can answer this. A child develops culture positive typhoid after 2 doses of Pcni. Will you give another dose? Will you give the 3rd dose of typhoid conjugate vaccine if the child develops a culture positive typhoid? We all see cases like these.
I will not give. I will not give.
You will not.
Yes.
Anybody will give? Anybody?
Infection acts as a booster.
I think there's a recommendation to give 1 dose. This child has received 2
Already received
doses.
2 doses.
This child has received 2 doses and still gets a typhoid. I think it's an inoculum-based disease. That's the main concept. If the inoculum is too much, in that situation, it may give a breakthrough typhoid.
So now we have only 9 minutes left. So we have to a little faster. 18-month-old child was given TDAP by mistake. So what will you do? Take it as a dose or give TDP, DPP or DPP at the earliest, or you wait till 5 years? 18-month booster is got as TDAP. Is it valid dose, not valid dose? What?
For me, don't repeat TDAP except TDAP, because if you repeat it fast with TDAP, you have more reactogenicity, especially with the tetanus and bacteria. So wait for the next dose, and since this is suboptimally immunized at 1.5 years, ensure that a booster in 4th year of life and then at 10 years is given. That will be my answer.
So you will not repeat the DPP dose.
It is okay. I think quite acceptable that once you have given TDAP, I think Dubai has done a study at 2 years and it's quite immunogenic TDAP. And in that situation, I think I'll be happy with giving, accept this dose as a valid dose and give another dose not at 5 years but at 4 years.
We'll give a DPP dose a little early.
Again, we've had this question in different forums and all. People are again divided. Some say that we will give it, and again, there is no Google answer for this. So, individual opinions, no study as such.
Google cannot answer the degree of mistakes we made.
So, anybody in the audience can tell us which is the earliest age we can give TDAP. This is actually an off-label use at 18 months. Earliest age? 7 years? No. In the PIL. Suppose you're given at 5 years, then it's not valid.
IHP says
But licensing is 4 years.
Which is the earliest stage you can give the TDAP?
earliest stage where you can give
TDAP. Officially.
TDAP.
TDAP. The product insert of Boosterix says 4 year onwards. Etacel, they have changed. Earlier it was available. It used to say 4 years to 64 years. In between, Etacel was not available. Now recently it has again come back to the market, and I checked the product insert. Now it said 11 years to 54 years. So we are giving it even at 10 years. That is also not licensed actually. I don't know why they have done.
No, there is some licensure issue. This was done around 1.5 years ago. When it was licensed, the study was done in this stage. So officially speaking, it's actually 11 to 44, 54 years, and the other one is 4 years on.
Booster is 4 year onwards. All those products are same.
Even at 10 years,
Even at
even 10 years, RSM is unofficial. So, similar question was Dr. Anurag was presenting the other day. Recently, a 12-year-old child was given DPT, HIV hepatitis B combo instead of the TDAP. What do you expect? Do you expect some side of
reaction.
I think there is in fact there has been papers of giving DPT experimentally to people after the age of 10 years. Before this era of exam, there was more reactogenicity and there was no other problems.
We don't expect anything like a convulsion or an encephalopathy or anything to be done, nothing to be done.
More reactogenic local.
So maybe we can reassure the patient that you might have much fever or something. That's it.
All neurological complications, whether it is because of the fever induced or pertussis induced, are in younger children, especially below 4 years, till the brain is unmyelinated.
Development. You had given 3 doses of Pcni to a child. Now you have practiced more than 30, 40 years. So 20 years ago, you had given this. Now the optician gets the HPS antibody done, and which is less than 3 international units. So what will you do? Give 1 dose again, booster, or will give the 3 doses again? This is again a practical question I have faced myself also.
My answer is no, because this matter, this pregnancy is not a kind of a high-risk situation as far as hepatitis B. But yes, if I find low antibodies in lab workers or someone who is living in an environment where hepatitis B is more transmissible.
Look, first time 20 years ago, we did not check that level. So we don't even know whether the child was responder or a non-responder. We go by statistics that most likely was a responder. But now, since the levels are low, we don't know whether you will give a booster or
Between 2010 to 2015.
you will not give a booster also.
Yeah, and between 2010 and 2015, there was a debate of booster for hepatitis B because many patients who had received in the 90s when this vaccine came had undetectable titers. So then it was said that only those who are in hazardous professions where there is risk of transmission would probably need a booster. Otherwise, because it has got a very long incubation period and CMI is a long-term memory, so they really don't require a booster, even the antibodies are undetectable.
We can change it slightly. Suppose this 20-year-old was a medical student. Now she's gone to a medical college. There the levels were done. So if the levels were done and they're found to be low, whether you will give a booster 1 dose only or
Yes, if in hospital environments, in
you will
medical
give 3 more doses,
you will give 1 more dose.
Only one more dose and you can check it.
1 more booster. Then
Check
You can
their
check the
levels,
titers.
check anti
Otherwise, not even one.
See, it is a very debatable issue. Now, we have been using hepatitis B in the world for last 30 years. And this question has been raised in Taiwan, this has been raised in Thailand, this has been raised after Alaska study. So, a lot of issues have been raised. So, one is if the level is less, is this patient not protected? We do not know. So first of all, we do not know. If we give a booster and suddenly the antibody titers are very high, so that is an anamnestic reaction. So if there's no anamnestic reaction, is the patient protected or not? Still, we do not know. So it is a very debatable point, but so far, most recommendations are there's no need to check the level, and the patient is supposed to be protected. But there is a caveat to that. There are 2 groups. One group is a group which is a high risk behavior. This has been studied in Taiwan. And the people who are at high risk, for example, the medical students. In those cases, the recommendation is yes, you may do these levels. If it is less than 1, then a full 3 series. If it is 1 to 10, then about 1 booster dose is enough. So this is what the latest literature today says. So this is there in the text. This is there in the literature. So it is not a question we do not know.
so most of the time, whenever I will try and find out, they said that you can give 1 booster, do a level again after 6 weeks and see if the levels are more than 5, then it's fine. If it's not, then it's responsible to do them.
It is to check for non-responders. Even after 1 dose, if you don't get treated, then probably that patient was a non-responder, which are about 10% after hepatitis B.
Maybe less, much less than 10%.
10%.
If the level is 3, this patient will respond.
A very interesting question, although we may not see it in our lifetime. You have a pair of joints. They are joined by the buttons, and more details about the physiology and are not. Will you give one to the two doses?
2 doses. We don't know the physiology. CDC says in such cases 2 separate.
So this is actually not a question which is not there in Google, and we did find something. This is the site IAC, which is the Action Coalition, Immunization Action Coalition site, which says that we don't know about this, and ACIP does not address this issue, but we feel that 2 doses should be given.
We discussed some time ago, and I think because if there's a ischiophagus, means it's joint at buttocks, there's not too much of crossover of blood because there's no major vessel involved. So in these cases, it's better to give individually vaccine. But if it is a fellow phagus and all that, that may be the one dose involved.
Okay.
Basically, for inactivated vaccine, which is the local lymph nodes which are recruited. So here, that is established. So for inactivated vaccine, treat them as individual child. For a live vaccine, you can have responses in both, but that antigen dose would fall short.
Since we finished time, this is the last question. Last question from you. Do you think what will be the schedule of COVID vaccines in 2025? Not on
No vaccine and no scare. It will be
No
a
vaccine, no
seasonal
scare.
endemic disease. Like you have OC 43.
I think now the data from Israel is there and from UK also there, that there's a waning immunity. It leads to more infections, but not significantly more deadly disease. So if you really want to prevent the infection, particularly I will be bothered about people who are more than 65, compromised. In those situations, I think booster may be given after 6 months to maintain their antibody levels.
But you
And
think
we do not
yearly
know,
booster will
and we
be
do
there?
not know if it is going to really help, but definitely going to help as far as infection part is concerned. I think that hospitalization and mortality, there will be a marginal difference. And regarding COVID schedule in 2025, I feel maybe if there's a new variant, then we'll need a booster, absolutely new variant. Otherwise, we'll be okay with whatever we received.
I agree, and I would also expect the vaccine which would give IgA, mucosal immunity, so better protection from infection. By 2025, that should be there.
We might be having a
These are vaccine which will give better.
So you also feel that yearly boosters may not be required?
It may not turn out to be influenza like we
And we
Winter
may
is
even
a
have
flu,
a
winter is a flu लिया था नहीं ना ये भी नहीं लो आने दो ना.
So
we may even
since
have
we have
a
finished time, there is no time for the audience question. We'll discuss over lunchtime. Thank you so much. Thank you all for this. Thank you.
Thank you, Speaker and Chairperson. So after the IPD discussion, let's open discussion. Let's move to the open discussion. Very interesting topic on septic shock. To chair the session, I would request Dr. Udari sir, is Director of Department Immunology, and next chairperson is Dr. Shamsi. He is very dynamic member of the IAP.
Hello, sir. How are you?
IAP.
Actually,
I request chairperson to introduce.
Dr. Nadeep, for your kind introduction. Now I have the pleasure to invite Dr. Praveen Pcni, who is the speaker from the session, Septic Shock and Dr. Praveen Pcni. He is Director Critical Care and Senior Consultant at Technology at Coaching. In fact, he is a great academician with a lot of interest in pediatric critical care. He has written a textbook of intensive care. He has been the vice chancellor of IMD intensive care chapter for the past 2020 and written textbook of pediatric intensive care. I mean, we can give a lot of knowledge about the good work done in the field of pediatric critical care. So I invite Dr. Pcni for
Good morning. Actually, while he's getting the technical glitch to open the PPT, I just thought I'll just chat with you as to what am I talking about. The sepsis issue is that there are guidelines that keep on changing. And we are fortunate that now we have 2020 guidelines, which are internationally accepted, which are somewhat taking into consideration the resource limitation also. So therefore, the IAP guidelines that we had created in 2010, 2011, they were also published. And now on that international level, South Africa, Africa, many of the countries, they accept these guidelines. So I think what I'm going to do is just talk about what to do and what not to do in septic shock. And this PowerPoint presentation is not private limited. It's shared on the IAP Delhi group. And because this is a guideline, we're not into that kind of copyright issue that it's a very private limited information. You need pen drive? Here you go. It's somehow when you load it over there, for it to come over here is taking some glitch. But please bear with us. This one. Thank you. So let's just go straight to the point. What is septic shock? Septic patient. Okay. So, and I should make a disclaimer. It may not universally apply to newborns, but since the guidelines have practice parameters for newborns and pediatrics, so there will be some overlap. But these are labeled as pediatric sepsis guidelines. Okay. So we'll just go over that. So I don't want neonatologists to necessarily think that we are dictating some kind of a particular antibiotic or anything. So just put it in perspective as to what are the things that you do and what are the things that you don't. Okay. So in adults, they came up with a sepsis definition because a long time ago we had a 2005 sepsis definitions. The big issue with that was that SIRS criteria were included in the sepsis. And SIRS, without having bacteria, you get near drowning, you are hypoxic, you get a multiple trauma, you get fever. That is not sepsis. So it was talked about that if you have pancreatitis, if you have hypothermia and stressful situation, trauma, that should not be all intermingled with sepsis, because it gets sepsis term gets used very often loosely. You have a patient who's sick, fever, inflammatory markers high, and you say it's sepsis. So that's why all of the experts went and they talk about what is the real thing that where you say cultures are not positive right away. So then they come up with pathogenous, the definition is essentially life-threatening organ dysfunction caused by dysregulated host response in response to infection. Okay, so they have simplified it. Take the SIRS criteria out. So let's just go to, since it's an unbalanced response, you will see pro-inflammatory marker and anti-inflammatory things, and there is a dysregulated response. So it gets very confusing as to who is a septic patient. What you will do is finally fall back on if the blood cultures come back positive, and they may not come back positive always. So that part is being worked upon now by the sepsis pediatric group to come up with difference. Okay. So we fall back upon what's the thing? Patient has fever, patient is fussy, patient is having tachypnea, there is poor capillary refill, and you start suspecting sepsis. So आप blood culture करोगे, you start IBM. Okay. So let's just go over this guideline, which is now published, guideline 22. So let me pick it up from the IAP intensive care chapter guidelines of 2009-2010. What are the do's? You do initial fluid therapy, and it was very, very widely discussed without any evidence that 20 per kilo बहुत ज़्यादा होता है. We need to give small aliquots of fluid bolus. Most of us agree, and now we have evidence. You know, after the feast trial, which was done much later in Africa, and they said that if you give too much fluid bolus, 20 per kilo, 20 per kilo, 20 per kilo, you end up loading the lungs and you end up going on the ventilator. So this is a major change that is happening. Malnourished patient who is a hypoproteinemia, you know, we all know that they will get swollen, the heart will get loaded. So I think it's important while we say we give fluid, but we don't go overboard. That means prevent the fluid overload. And now there are studies which are saying that if during your process of treating, if you have a fluid overload of more than 10%, do early RRT and you have a high mortality still. So don't let the fluid go up and up and up. Okay, so I think we'll just talk about it like in dengue, leakage situation, you have to give fluid. So please don't take that message that we don't want to give fluid, but just achieve only 0.5 ml per kg per hour urine output. You don't have to target for 2 to 3 ml per kg. Okay. So let's go on. Big change that has happened is dopamine gets used as water. Now they have come up with this that if you use epinephrine as the first inotrope available after fluid, you have a higher chance of survival as compared to dopamine. Big study came from Ramaswamy et al. From Pcni. Okay, so that has made international impact. PAS guidelines also talk about now that you will use epinephrine as the first line therapy immediately after you have given fluids. But if you don't have epinephrine, you use dopamine. So I want to be very clear that it's not like dopamine has been thrown out of the window. In adults, it had some issues with endocrine issues and not good response. But in pediatrics, still many places use it, and so dopamine gets used. But they do talk about that if you give epinephrine as a first choice, it's a good idea. And where in any of the peripheral situations you don't have epinephrine, everywhere you have it. You have epinephrine for allergy, you have epinephrine ampoule on every code card. So therefore, question of non-availability is not there. So that's why even our ALS guidelines for IAP are adopting it. Yeah, epinephrine use. Okay. So now what about ongoing fluid therapy? As I said, don't overload. Keep getting guided by vital signs. So you again fall back on perfusion, heart rate, mixed venous saturation, sensorium, respiratory rate, CRP, blood pressure. In addition, they have now added, okay, if you have availability of getting lactate, it has a question mark. There is an Andromeda trial that has come up now. They talk about lactate is as good as perfusion. Okay, monitoring lactate. So if your perfusion is bad and your lactate is high, so after doing a blood test of lactate, what major thing you have achieved? So they're falling back upon the same old notion that perfusion is good enough. So if after you've given fluid, if your perfusion is getting better, you're okay. I am not saying that categorically right now because current sepsis 2020 guidelines do recommend follow lactate as well. So that's why I just put question mark on that. Lactate. Cardiac contractility. How things have improved. In the past 10 years, average pediatric ICU person average neonatal ICU person who been doing ultrasound of the head for zillions of years now knows how to look at the cardiac contractility without a cardiologist. All my due respect to the cardiology, at 2 a.m. when you are with the patient, and if you have an ultrasound probe, like butterfly probe that comes, talk to Dr. Dhiren and many of our interactions, they are all using it. You come to know cardiac contractility, poor, pericardial effusion, lung ultrasound to see bubbles, and V lines and all these things. And then look at the abdominal IVC size. If the IVC is collapsed, you know that you need to give fluid. If the cardiac contractility is low, you know you need to give alcohol. So for ongoing fluid therapy, if the IVC is collapsed, you are able to give fluid. Okay. But suppose, sir, I don't have ultrasound. Okay. I'm just saying you all should learn it now. If you don't have ultrasound, then you fall back upon the same thing. Perfusion, heart rate, give fluid, see the response. Nahi aa raha response, so try kar lo epinephrine. Epinephrine will vasoconstrict also and will also give you cardiac contractility. So that's why they said, okay, if you are in a poor resource situation, you don't have ultrasound availability, you use it. And this is internationally accepted. So it's very good that our people like Dr. Suchitra Ranji, Dr. Jayashree, many of these people have been on those committees where we are able to say our limitations, and they are accepted. So let's go on. What is the other do's? Always do blood culture. Don't give empirical antibiotic without doing blood culture. Get a chance, draw a CBC, give a blood culture, get a blood culture, फिर आप दे दो. And then you can go ahead and decide on the antibiotic as a broad spectrum initial therapy. So if no pathogen is identified later, let's say if this was a SARS kind of issue, please discontinue antibiotic. Patient is stable. Don't commit to a case of 21 दिन. Like in newborns, you all do that. But in pediatrics now, they've just started talking about that if your cultures come back negative, patient is hemodynamically improving up until 20. So therefore, we generally do 48 hours and then end up stopping it. So the duration increases if there is an immunocompromised patient that you know earlier. So that's why this doesn't overlap in immunology, because by definition, newborns are considered somewhat immunodeficient. But it's not something that I would like to comment on this, the duration of therapy. But in pediatric sepsis, the guideline is blood culture, give antibiotic, and you carry on then later on de-escalation. So if the patient has been admitted to someplace else for 3 days, it has come to you, maybe you need to start not third generation sepsis for it, piperacillin a little bit. But please don't jump on. Okay, so that's like a clear message that don't start your big guns. Okay, so I've already talked about antimicrobial therapy. Don't forget source control. That's a big do. Look at pustules, lesions, anything that you think where the sepsis could be coming from. Unfortunately, many of the kids, you don't find a sepsis source, so you have to go with the clinical markers and inflammatory markers. Okay, if there is an intravascular device, palace chronic central urinary catheter, do think about it, that you may have to remove them. But abscess debridement and all that goes without saying. You all are aware of that. So now, fluid therapy ongoing is what we need to talk about. Once you have admitted to a monitored situation, and once the patient gets a little bit stable, you can consider colloids. Okay? Earlier, crystalloids. What is the most important available crystalloid? Normal saline. But they say if you keep giving normal saline too much, then it will cause hyperchloremia. So therefore, they say balanced crystalloid, इसमें आप रिंगल भी use कर सकते हैं. Okay, so it's got a little bit less chloride. So essential thing is don't fluid overload. So that's a big don't. No starch, no gelatin. And I'm saying this because Himaxil and a lot of things people use, they have been shown to cause renal failure. So you'll have an issue if you start giving starches and gelatin. So that's not being recommended. But other colloids which are available to you, like albumin, like when you end up using FFP becomes a colloid. But I'm not saying that you use FFP just because you want to give a colloid. FFP has different indications. That if the patient is bleeding, then only you use FFP. Okay, so now hemodynamic monitoring is a big deal. Whatever line you can get, arterial line, this thing, start monitoring. But now, for us, non-invasive monitoring is available, pulse oximeter, and then you're able to non-invasively get the echo, ultrasound. So not every patient needs a huge central line, 2 central lines, but the sick patient where you need the access, you need to do that. Okay. Follow trends in blood lactate level. There, a word of caution. Patient who's got a lot of adrenaline can have a high lactate level. Okay, so just keep that in mind. The lactate is not to be blindly taken as, it needs to be put all together. If you have a familial disorder, lactatemia, it will cloud that issue. Vasoactive medications I already talked about. Use epinephrine first. Now, suppose if the patient is totally vasodilated, pulse pressure, flushed capillaries, then add norepinephrine. Okay, tight pressure. And when we use vasopressin, and all of these I'm talking about are backed up by studies. Now, it's not just expert opinion. So in vasopressin, they all talk about when it's a total peripheral vasodilatation, despite giving adrenaline and noradrenaline, then add vasopressin. Again, if you look at the studies, it hasn't made a difference, but they say that it should be used as a last resort. So now what about ventilation? Past 10 years, we have also realized that you don't have to intubate every septic patient. Earlier, we used to say, no, you have to intubate and this, that. Now we say, if the patient is symptomatic, let's try NIT, non-invasive ventilation. And maybe if sepsis settles down, it may not end up going to ventilation. So that's the change that has happened. Okay, prone positioning. This is one thing that is known now, that you can prone the patient who is the ARDS, and it helps. Okay, and there is evidence, and there is a mortality benefit of that. Okay, nitric oxide as a rescue therapy only in patients documented with pulmonary hypertension. So nitric oxide is not to be recommended. No recommendation to use HFOV. So please understand, now there are lots of studies, they don't talk about, they have refrained from that HFOV, but we as pediatric intensivists still use it as a rescue therapy and not really jump on that. Newborn is a different story, because PPH and HFOV is the established. Neuromuscular blockage. ARDS, thick patient, 17-year-old obese patient, ARDS, you will have to use muscle relaxants. So they say, use muscle relaxants only sparingly to improve the chest wall expansion because it relaxes the muscle, but not otherwise using it indiscriminately. Corticosteroids. And no. So right now there is evidence against it. There is evidence, little bit evidence for it, especially in patients with nephrotics, chronic steroid dependent, where you know that there is a adrenal suppression of this thing. There is no controversy. But after you've given fluid, catecholamines, if you routinely use steroids, evidence is not there because it causes hyperglycemia and side effects. So let's leave it to that. And then endocrine, metabolic, no routine insulin, no consensus about what blood glucose range to follow. Why we say this is maintain normal glycemia. It's simple. It doesn't take rocket science. So if you have a hyperglycemia, they do insulin. Nahi hai, so dextrose they do. Maintain normal glycemia. Okay. So no consensus whether to target normal blood calcium. So if the calcium is low, just give it. But there is not evidence enough that if you have a little bit low calcium, that you're not going to come out of sepsis. So there are experiences people say, why maintain a low calcium? Give calcium to maintain normalcy. No routine of levothyroxine. Many of the people just tend to give thyroid when shock is not improving. No recommendation on that. Antibiotic therapy, fine. Blood products, don't. It's a big don't. By no transfusion if RBCs, if the blood hemoglobin concentration is more than 7. So if the patient is on oxygen inotropes, then you need to maintain hemoglobin of 9. If the patient is not on those, 7 is okay, and nothing is going to happen to the patient. 7 se niche gaya, blood. Okay, so once the hemodynamic stabilization is defined as MFP higher than 2 standard deviations. So basically, just one has to maintain that. No consensus of hemoglobin transfusion threshold for critically ill children, but this is the general overall background studies which talk about stable, maintain 7. If it's unstable patient on oxygen inotropes, maintain 9. Okay, no prophylactic platelet transfusion for any level. Okay, so their word of caution that I use is very small, 1 year and under baby who comes with dengue has got platelet count of 10,000. There is a legal issue. If you don't correct it and he gets intraventricular hemorrhage, there is a legal issue. But we cannot apply all of those to as a general guideline. So there is no particular platelet number. If the patient has evidence of bleeding, you do platelets, you give platelets. And if the evidence of bleeding, you give FFP. So not just on a prolonged PTPDT that we have to give. Another tool, and this is just the last slide, use renal replacement therapy early to prevent fluid overload. Plasma exchange and extracorporeal supports. Out of all of this, the only evidence is veno-venous ECMO. Suppose nothing is working, try veno-venous ECMO if you are an ECMO center. Otherwise, try to prevent fluid overload. और ये जो कहते हैं ना टॉक्सिन निकालती है, एक्ट पे डाल दो, has not been proven beyond doubt. Okay, so that's still in the experimental phase. So let's talk about IVIG. This also gets very indiscriminately. No is the recommendation for IVIG routine use. They have still made a word of caution that in few select groups where there is benefit, so you may want to try. So that's why it's a little bit diplomatic answer that you will use it, the patient is not getting better as a last resort. But if you ask in the recommendation, they have not put as a routine use of IVIG. No routine use of stress ulcer prophylaxis. Okay, so this is one more thing we use very indiscriminately, Zantac, Rantac, start feeding early and you don't need any intensive. Okay, so no routine deep vein thrombosis. Here there is a word of caution. Teenagers can get deep vein thrombosis. In adults, they use deep vein thrombosis prophylaxis. In pediatrics, so there is no recommendation on deep vein thrombosis. So last slide, assess in every patient every day what is the intake, what is the output. Are you fluid overloaded? So if you are fluid overloaded, try to achieve negative balance by giving less fluid or using diuretics. Okay, so that's one thing. And then I'll leave you with this thought. Distinguishing a sepsis survivor from non-survivor on day 1. There's a fascinating study that came from Cincinnati Children's Hospital, Hector Vaughan. They just looked at this patient with sepsis is not going to live, and we do the entire thing. So some of the answers are coming from genomics. They look at the gene array and they say this particular gene array is not good for survival. And the other person who has the same illness, same parameters, ends up making it, given the same intensity. Anyway, I'm leaving you with this thought only to not get, please, discouraged. Treat everyone. Don't say genetic markers. So I think I'll leave you with that thing, and then so a lot of answers are coming from transcriptomic profiling, genome profiling, molecular biology to see the susceptibility. And so these are the references. They are already on the PPT, which is shared on the group. Okay. Thank you very much for the patient. And finally, I'll just show you one picture. These are the people who keep us going. You know, when they live, when you see the smile on face of the father, तो बिल कितना भी हो वो खत्म हो जाती बात ठीक है. But be communicative, talk to everyone, tell them that ये नहीं कि हम guarantee है हम जहाँ तो चलेंगे और ये कर देंगे, because when there is that kind of overconfidence, results are not good, they get angry and there is violence. So please communicate every day about these things. And I will say my personal experience. I've done very well with this kind of thing most of the times, but we still have security. We still have the laws, and that's important. But communication is very important. Thank you.
Thank you for a wonderful talk and for sticking to the time. So we have a few minutes for questions if there are any. Any questions from the audience? Yes, sir.
Can you pass the mic, please?
The hydrocarbon is not recommended. Then we still give start dose of hydrocarbon just to.
Let me just say this. When I said in the recommendations, answer is no. No steroids. Every steroid is somewhat related. But suppose you have a patient who is already on steroids. Okay, steroid dependent, SLE, nephrotics. There, what you need to use is hydrocortisone, 2 mg per kg as a stat dose, and you can carry on because you have to support it. But otherwise, in a normal child who's getting sepsis, they're saying don't routinely use steroids. आप fluid दो, inotrope को titrate करो, you should be able to come out. Okay.
Planning to put the child on the ventilator. Then which mode is
You see, that's a separate part of the ventilation workshop. But when you do ARDS, you talk about volume control and PEEP titration. So I just leave it to that, because the rest of it, when you have pneumonia, when you have normal patient who's having Pcni, different modes are used. Inodilators are not routinely.
Thank you. Thank you, Dr. Kilani. It was wonderful listening to you again. One of the good things about, a good session is defined by a good topic and a good speaker. We've had both today in Dr. Kilani. Thank you very much for being a very patient audience. Thank you to the organizers for inviting us.
Thank you.
Thank you, sir, for a wonderful talk on such an important topic. Thank you, chairpersons. Now we will move on to the next session, that is a session on the DPT vaccination, and for which I would like to invite the chairpersons, Dr. A.K. Sharma. Sir is the founder of the IIP East Delhi branch and also the founder of the Delhi chapter of the respiratory chapter. And we have also like to invite Dr. Piyush Khanna. Dr. Piyush Khanna is the current executive board member of the CIAP as well as the chairman of the Body Movement Center. He has held multiple positions in the past as the secretary and the past president of the West Delhi branch. Over to chairperson.
Good afternoon, friends. This is the session of bread and butter DPT for all of us. So now let us see what
Dr. Sharma and Dr. Piyush. So we have been having a wonderful session since morning. They are starting from urology, the intracranial pressures, the intensive care, shock. And as you always say that bread does not taste much if there is no butter in it. And that's exactly the vaccination sessions have been interspersed between the septic shock and dengue session, so that the butter keeps on coming. So my topic is very simple. We have DPT vaccinations. All of us have been doing it for many years. It was part of the initial vaccination program of the country. DPT came. Now a lot of things have happened, and I will be suggesting that there will be certain changes which have happened in recent past, which may stimulate us to do vaccination a little better efficient. So what is the circle of DPT vaccination? Just before the talk, Dr. Sharma was asking you, what are you going to talk on this? So this is exactly what I'm going to talk. The circle means that we are giving DPT vaccinations right from the primary vaccination, which now we are dealing with a combination of DPT, OU, hepatitis B, as most of us either use Penta, which is in the government schedule, or we use
XR, whether it is EZ6 or whether it is accelerant vaccine, Xaxim and Fendrix vaccine in private schedule. That's a part of primary schedule, 3 doses. So there the issue comes whether we are using whole cell or whether we are using acellular. So at the outset, I say that both are equally good, but I will try to highlight one of the important points which make me more comfortable using acellular vaccines. Then we are using booster, 16 to 18 months, DPT and polio again, the whole dose DPT and injectable polio. And then there is a recent recommendation from IAP to use a second booster of DPT and IPV. This is between 4 to 6 years of age. This is a recent addition of the IAP schedule. And then TDAP or the low dose diphtheria and low dose tetanus and pertussis, which can be used anytime beyond 7 years. So that means, and as we know that even in obstetricians, obstetric patients, you can use DPT vaccination. That is what is completing the circle of DPT vaccination. And why we are saying so? Because it's a acellular vaccines which complete this circle. You can use it as a primary dose, you can use it first booster, second booster, you can use it as the third booster, and then you can use it throughout the lifespan of an individual. So why we need vaccines? These vaccination diphtheria. I have not seen diphtheria in last 25 years. Some of my colleagues in government sector must have some, but definitely it has come down. I have not seen tetanus in my medical college. My medical college, we used to have a tetanus ward. But during my tenure itself, when I became SR, the ward had to be closed because we have no tetanus even in 95, 96. Now we are already in 2021. So I have not seen any tetanus patient in my tenure in Gangaram Hospital. Polio officially it has been eradicated closer to 10 years now. Hepatitis B, we do see, but rarely perinatal because of the hepatitis B schedule at birth. HIV, in my tenure, I've never seen a culture positive coming HIV. That has also been a success story. So what we are left with? We are basically left with pertussis, which we all keep on saying. So we should try to keep our vaccination in such a way that we keep everything, but we keep pertussis in mind. Why we need acellular vaccine? Because there is association of fever, swelling, irritability, not feeding, encephalopathy. And as Dr. Nita in the morning session also told us that Levet syndrome, in which there is a chances of encephalopathy, you only need to use acellular vaccines. That is why we use acellular vaccine to complete the circle of DPT vaccinations. This is a forgotten disease. I'm just highlighting from my own experience. A day 11 of baby cough with no distress came to me with access just like this, right upper lobe collapse. Required ventilation, nasopharyngeal biofilm was sent. So fortunately, we have this technology and we are going to have a session tomorrow in this call at this time also on biofire. We will be discussing that how it helps us. This is what biofire can do. There's a lot of targets covered. PCR based technology in CSF. You can do it on CSF as well as blood. And in this case, we did from respiratory passage. And we sent the nasopharyngeal biofire, something like corona, our PCR based technology. We are right now we are seeing a lot of RSV because of this biofire technology. So we do Bordella pertussis. Unfortunately, baby developed persistent pulmonary hypertension of pulmonary hemorrhage, and despite exchange transfusion, despite azithromycin, despite high frequency IMU, baby still died. This means that pertussis is still there in this world, and we have to diagnose it to know it more. And that is why this baby could have been prevented if the mother could have been vaccinated from DPT, the TDAP vaccination. Another case of 14 months old baby respiratory failure, ventilated. So it was asynchronous ventilation. We started now on this baby, and despite this, you know that ultimately, what was there was pertussis. Same baby pertussis is still there in newborn period in infancy. We are evolved from the whole cell to acellular vaccinations, and there are two forms of acellular vaccination available: liquid form, which is totally liquid, don't have to do anything, and a reconstituted form. It is expected that the immunogenicity safety has to be proved. Whenever you think of, you have to prove it. It has been proven against whole cell, which shows a lot of batch-to-batch variability, versus acellular, which does not show that much of variability. It appears that the future is there of liquid preparations, more combination vaccinations to come. So whenever I discuss with my patients that how to choose, I say that ultimately all of them are immunogenic, they are good vaccines. You are looking for more safety and less fever swelling, you can choose the acellular vaccine. And when I was choosing the acellular vaccine, there are two, which is reconstructed and to reconstruct.
Then I asked them that whether you like to drive a car which is without a gear or with a gear. So if you're comfortable with a gear car, you know that there are going to be some jerks, the car will stop in between, and you have issues, it will cost you less, but you can choose that. But if you want to drive a clutchless, a gearless car, you can choose ready to use accelerated vaccine. Is there evidence that which one is better? There is some fully liquid accelerated vaccine that titers against pertussis, polio 1, polio 2, 3, hepatitis B, HIV, all of them have been shown to be better than the reconstructed one. So we have some immunological data to show that it is an immunogenic vaccine. And also another point is concomitant admission with other vaccines. We cannot give only this. We have to give other like pneumococcal also, rotavirus, pneumococcal, MMR vaccines. So they have been shown to be safe if we give, even if you give them in combination as a part of the catch-up vaccination with these vaccinations. So there is a little issue with the reconstructed one, which is shown that maybe with PCV10, if you use a polio, there is some inconsistent antibody response. And that is why there is some difference between the reconstructed and the ready to use, not only from immunogenic point of view, which I said before, but also the concomitant use. And unfortunately, we don't have a co-administration data for the whole cell vaccines, which we are still using. Also, the reconstructed vaccine has a better technology for hepatitis B, which is called Anisula polymorpha. That's a type of way of preparing. Initially, when we started hepatitis B, it was coming from the serum. A lot of reactions were there. Now the genetic engineering came. So as part of genetic engineering, hepatitis B is stronger. That is why there's more immunogenic and ready-to-use vaccine. Also, it's a convenience also. Less time to perform vaccination, reduce wastage, reduce occurrence of human errors, handling errors. It's possible that once you reconstruct, the total amount may not come, or you may forget to dilute it with the HIV component. There is reduced health exhaustion, cost reduction, because ultimately time is money, and preparation is in lesser time compared to the one which you need to reconstruct. Is it that pre-filled syringes are better? Ultimately, if you're seeing now, a lot of vaccines are coming in pre-filled syringes. That means technologies move into that. That is, if you have availability of pre-filled, liquid, ready-to-use vaccine, there's a scope to do that. Is there some evidence from India? Yes, there is. Dr. Kasi, Dr. Chitkara was there in the morning. They have published the data from Indian time and motion study. We looked at that whether the way it is handled by pediatricians in India, do they feel liquid to use? There's a long post barrier. Most of them prefer that liquid ready to use is better. Reconstruction errors are definitely going to be lesser. There are errors which are possible. All of us are human. There is human, we can err, and that is why it was the Texas in the morning to give hospital, but you do. So we know that human errors can happen. So if you can reduce the errors, you can use a fully liquid vaccinations. Apart from that, there are certain new ACP guidelines have come. I'm sure all of you must have read this beautiful paper by Dr. Kasi, Dr. Piyush, and Dr. Sunil. Everybody is there on this. That what has changed? They have changed something about the polio, injectable polio vaccine. Now, a booster of injectable polio is recommended at 4 to 6 years of age. And till that time, government was not having a lot of doses of injectable polio. It was being given as 0.1 ml, intradermal, only 6 weeks and 14 weeks. Then the booster came at 1.5 years. Now they are also IAP is recommending at least to give it at 4 to 6 years also. Also, the same paper recommends that you can use DTaP, that is bacteria, along with IPV combination, which is again a preparation available to you liquid form between 4 to 6 years of age. So latest ACP recommendation, I'm sure all of you must follow. It shows that you have to give 2 boosters of injectable polio, one between at 16 to 18 months, another at 4 to 6 years. Also, it is important to say here that here DDP vaccine is only recommended before 7 years of age. If any child comes to you beyond 7 years, it is expected even from IAP point of view to give a acellular vaccine. That is why acellular vaccine is the vaccine which can cover the whole spectrum of population, starting from the pregnant mother to primary dose, and then even at booster 1.5 years, 5 years. So why was polio booster considered? I think all of us have seen that polio is a morbid disease, but we don't see polio. So why we need boosters? Because anti-polio immunity wanes over time. As we see that there is decrease in antibody levels,
and anti-polio immunity increases every time a booster is given. That is why it is recommended that 1.5 years also we give booster, and now at 5 to 6 years also we give a booster. Why so? Because there is a gradual decrease of antibody titer, and the most important thing is that right now, current epidemiological situation, you are seeing more issues of the vaccine-derived or vaccine-associated polio virus, paralytic polio. So with IPV, we know that that risk is not there. So if you want to use a booster, we are not in favor of using OPV as a booster. We in favor of using IPV as a booster because we don't want vaccine-associated or vaccine-derived paralytic polio. And as WHO is also saying that we must cover it till 5 years of age. That is why even pulse polio doses are to 5 years. So why not leave those children unvaccinated if the boosting effect is available to us as a combination of DPT and IPV? Also, we know that latest case of wild polio was reported on 13th January 2011, and even from Southeast Asia after 27th March 2014, no case has been detected of wild polio. But we should know that another type of polio, the community vaccine-derived polio viruses, are still circulating. So we know that we cannot do that from government point of view to give injectable polio throughout, like pulse polio is oral dose much cheaper. But yes, India comes still under the category of countries where there is a high risk of CVDP, and that is why we have a large border also with Pakistan. So we always at risk of wild polio also. But right now for us, the community-acquired vaccine polio is a disorder which we need to keep in mind, and that is why at least I will be saying that in private practitioner, office-based practice, we prefer injectable polio. Polio is alarming epidemiological situation. You can see red, Afghanistan and Pakistan. I'm sure Afghanistan is going to get worse after Taliban have taken care of that. But yes, we should be not only be scared of terrorist attack, this is also bioterror attack of polio in our country. We should not keep our alarms down because we are still scared of wild polio. So polio eradication initiative has been there, but issue is that over a period of time, the wild polio virus has gone down and the community, the vaccine-derived polio is going up. So we need to take care of that by using injectable polio vaccines. So that is why, as was discussed in the panel also, that we should, once we have a full dose DTaP available, we should not be using TDAP. Why? Because there is a higher dose of bacteria, it is more than 20 IU compared to 2 IU in TDAP. Higher dose of bacteria, it is 40, is 20 in TDAP, and higher dose of pertussis, which is 10 times high, 25, against 2.5. So if you are convinced that we are seeing more pertussis, still at 5, 7, 8, 10 years, I'm sure I don't need more argument to say that you should be using the whole the TDAP, the TDAP cellular pertussis, and not the TDAP, which gives you only 1/10 antigenic load of pertussis. So that is why once this vaccine is available, I have been using only this as a booster between 4 to 6 years. So these are the recommendations from ACVIP that they are saying that 15 to 18 months, 4 to 6 years, and if you delay, you can use same vaccine till 7 years. After 7 years, we expect to use more dose because of the less immunogenicity which is there in the TDAP vaccination. Boosters are needed because ultimately boosters are important to take care of the waning immunity. So I will take home the points, and I'm happy to say that pertussis is a disease which are able to diagnose now with the help of the PCR technology, BioFAC. Acellular vaccines are efficacious. Only thing is that you need to stick to the schedule. We make it sure that the child gets the primary 6, 10, 14 or whatever you are following, the booster in time, 15 to 18, 4 to 6 year booster, 10-year booster, and then it is as good as the whole set from immunogenicity. It gives the comfort of completeness. This is one vaccine which can be throughout the generation. That is why the complete age from birth to old age, lesser side effects, ease of administration, preservative-free, better immunogenicity, hepatitis B scores compared to the one which other acellular vaccine of vaccination can have. Thank you so much for giving me this opportunity.
Dr. Pankaj, I think you have beautifully summed up everything in very short time. I think you exceed the time that you needed.
Yeah, the organizer, you have to do that responsibility also.
And you didn't go that fast also that people didn't understand. So that was commendable. The house is open for questions in case there are any.
I think nobody can question the secretary.
That is because he's a brilliant academician or he's the organizer.
you so much. I think that there are no questions because most of the questions have been already asked in the vaccine in the morning. Thanks so much.
Thank you. We close the session now. Thank you very much.
The next session, very relevant in this monsoon and post-monsoon times. It's on dengue, hemorrhagic fever, and dengue shock syndrome best practices. And I'm by Dr. Shobna. She's a senior pediatrician working with BMC and Sahaja with more than 50 years of experience. And also Dr. Shravan Gupta, who's a senior pediatrician working in West Delhi. Welcome to the chairperson.
Session on dengue shock syndrome and dengue hemorrhagic fever, delivered by Dr. Amit Tehra. Senior consultant pediatrics, pediatric critical care pulmonology, Professor Photo Hospital, Delhi. The area of interest are pediatric mechanical ventilation, cardiac critical care, fluid and hemodynamics. Dr. Amit.
Thank you, Chairperson. So, in the next 15 odd minutes, I'm going to talk about dengue hemorrhagic fever and dengue shock syndrome. And I'll keep it brief and give you an overview rather than going into the details of most of it. But we know for sure that the dengue fever is not one disease, it's a spectrum. You can have something that's a very mild asymptomatic seroconversion to a very, very severely affected child who has a full-blown multi-organ dysfunction. So some children will not even need to see a doctor versus some who will end up in intensive care units and very, very sick. Typically, the dengue fever goes through these three typical phases. There's a febrile phase, then there's a critical phase and recovery phase. Not all children will go through all these three phases, but most children with the hemorrhagic fever and shock syndrome would go through these three phases with various different timelines. So some would progress very rapidly, some would progress slowly, and that makes the job more challenging as to identify the child at the right phase. WHO changed the definition in about 2009 when they took away the terms of dengue fever and dengue shock syndrome and just classified this dengue fever with or without major signs, and then severe dengue, which encompasses our two topics of dengue hemorrhagic fever and dengue shock syndrome. So it is intuitive. The more sicker the child, the more severe the dengue is. The warning signs that we have to be aware of are listed here: abdominal pain, vomiting, poor oral intake, irritability, increase in hematocrit. All of these are danger signs which might happen much before the child goes into a full-blown hemorrhagic shock or shock syndrome. But when the child does go into that, the three main features of a severe dengue are severe plasma leakage, severe bleeding, and multiple organ involvement. The organ involvement could be one or more than one organ. But something which is very typical of severe dengue is the severe plasma leakage. Leakage is something that we have to be aware of, and all our treatments are actually guided towards this this component of the pathophysiology of dengue. So the clinical manifestations of plasma leakage we are aware of, and the temperature and platelet drop may often precede this thing. So your platelet drops will already be happening when the leakage starts. Hematocrit increase is one of the earliest signs, and that is why there is an emphasis on repeating hematocrit and looking after serial hematocrit numbers. the increasing leakage might not actually manifest till the child gets fluid. So the child might actually come to you without too much leakage. You give the child resuscitation fluid, and that might trigger off the leak. And then is when you would start seeing the cycles, pleural effusion, tachypnea. And this is not unusual. This is, I would say, very common, especially this season's Chinese shocks which are coming to us. So, as I said, leak might not manifest till you start hydrating them, and early detection by ultrasound would be a possibility. Dr. Pcni mentioned that we use ultrasound machines very frequently these days, and we are able to pick up these leaks much earlier. So, the treatment for the leakage is obviously replacing the fluid, and this replenishment is the cornerstone of the treatment of daily emerging fevers and the shock syndromes. And the question again comes, how much to give, how fast to give. Again, there's no single prescription, but you have to follow what is happening. So if the child is in shock, you need to give a lot of fluid and you need to give it very quickly. If the child is not in shock or in a state of compensated shock, you still have to give fluid and you have to match the losses which are happening. So we have to match the losses. And the concern here is the losses are internal. They are not happening outside. It's not diarrhea or blood loss. The losses are happening internally, and you have to somehow estimate the loss and make up for the losses. And hematocrit comes in very handy to estimate the losses of fluids which are going on. So which fluid and what if fluids are not working, right? So the concept is that when you give some fluid to any child, there is an expansion of the intravascular compartment and the blood pressure or the hydration is maintained. So when you use a crystalloid, you give a crystalloid to a child, after a certain amount of time, most of the crystalloid leaks out. In fact, after 1 hour, about 30 to 40% of the fluid is outside. And after about 3 hours, almost 75% of the fluid leaks out. So a child who gets, say, 4 liters of fluid, only 1 liter remains intravascular and 3 liters goes outside the intravascular compartment. And a child who needs multiple such boluses with multiple leakages, you can assume what this leakage or accumulated fluid does to the body. So that is why the concept of colloid. So in extracellular fluid, if you use colloid for expansion, you have larger molecular weight colloids. This would hold on the intravascular volume longer. So even after elapsing of time, the intravascular volume would be maintained for a longer time. And you can see this in this particular study, the volume expansion with the colloid, 5% colloid versus crystalloid is significant. 25% for a crystalloid, almost 80 to 100% for albumins or colloids. So that is why there is an emphasis on using colloids early for severe dengue shocks. Now there's also a small twist here with dengue. The dengue capillaries are not normal. They don't have tight intercellular junctions, they are leaky. So when you have a leaky capillary, the fluids that you give, no matter what fluid you give, crystalloid or colloid, some of it is bound to leak out. More for crystalloid compared to colloid, and this over time again will cause edema everywhere in the body, including all the body organs. So, and that is why you have this edema in the heart, causing myocarditis, in the lungs, causing pleural pulmonary edema, pleural effusions, hepatitis, brain causing encephalitis. So all this fluid which keeps getting accumulated in various parts of the body keeps on causing more damage or causing more multi-organ dysfunction. So what fluid to use? More crystalloids and colloids. There was a study in children using 3 different fluids, the dextran, starch, and ringer lactate. This was done in Ireland in children. And in terms of outcomes, there was no difference in outcomes. In short term as well as long term, the outcomes and resuscitation outcomes were similar whether any of these fluids were used. Yes, children using crystalloids needed a longer time to resuscitate well. FFP colloid, so many albumin is costly, FFP is costly as well, but FFP also has many other factors. So many people use FFP as colloids. There are concerns about FFP being a blood product, But there are some experimental studies which actually say something might actually be better than even albumin or 4.5 to 5% albumin as a colloid to maintain intravascular volume, not necessarily only in dengue, but in general as a colloid resuscitation fluid. So the WHO guidelines, which have been widely publicized and have been around for more than a decade now, give out some guidelines as to how to give fluids. So whether the child is in compensated shock, which means the shock has not yet caused hypotension, versus decompensated shock or hypotensive shock, the fluid management varies a little. And as you can see here, the idea is to give more fluids. The whole idea is that you are losing lots of fluid in the body internally, and you have to match that fluid loss with the fluid intake. And the fluid recommendations are very generous, right? So this is out for people working in the community, and this is probably what is saving a lot of lives, but we see a different aspect of it as well. We often find children with lots of fluid overload who come to us referred when fluid alone are not working, and that becomes a bit tricky. So most of the fluid recommendations from WHO are based on the requirement of fluids for resuscitation out in the community where children are already losing fluid, and the emphasis is to give more and more fluid. Child who's in hypotensive shock, the idea is to obtain a hematocrit and then track the hematocrit. If the hematocrit is rising significantly, if the hematocrit is rising, it is an indirect indicator that there is hemoconcentration happening and you're losing or oozing fluid within the body outside the intravascular volume. And the demands of the crystalloids or colloids are higher. And if you would go back to the previous one and this one, the only real change is there is a earlier recommendation of colloid use when you are hypertensive compared to a crystalloid use in children who have hypertensive shock. So there is plasma leak with shock, and that is the main problem with dengue. Initial stages, there would be compensated shock, which gradually worsens, and this is what happens in dengue. You start off with dengue without warning signs, with warning signs. Within hours, this can go on to compensated and decompensated shock and can rapidly progress into cardiorespiratory failure. Our job is to detect children much earlier than they reach this phase of cardiorespiratory collapse, because when some children who reach that phase, they go into this phase of cellular death. So even if you are able to maintain and normalize the hemodynamics, you sometimes cannot get the cells to use the nutrient that you are pushing through. This cellular death sometimes is a very common sign for children with dengue. The pathophysiology is complex. I don't really want you to go through this. It's just to show you this very complex. That slide is there. So it is not just the fluid which causes the problem. It is also the pathophysiology of this viremia which causes multi-organ dysfunction and involvement of so many different organs. So there are complications because of involvement of just about every organ system: myocarditis, kidney injury, encephalitis, liver dysfunction, respiratory failure, refractory shock, DIC. Dengue can cause all of this, not just because of edema, tissue, interstitial edema in these tissues, but also because of the viremia itself per se. But the good thing is that even the worst of these can sometimes turn around. So children with dengue who come with liver failure and fulfill all the criteria of a liver transplant, even they turn around. So this is one category of liver failure where we would keep pushing and not really go for a transplant because we know this will these people would get better. Myocarditis, again, unless in very severe stage, they also tend to get better. There is a massive inflammatory response, and people have measured ferritins as a surrogate for the inflammatory response from very, very high ferritin levels as well. And initially, it was thought to be a very poor prognostic sign. Of late, we understand that this is just a marker of a very high inflammatory state and not very necessarily a marker of poor prognosis. It just tells you inflammation, and if you have more inflammation, the disease is probably bad. That is why you have a more severe inflammation. Most of the management, if the children are very sick, would need organ supports, and these organ supports are probably best done in intensive care units. When you are in a stage of fluid unresponsive shock, judging fluid clinically sometimes may not be very easy. And you have to rely on the tools that you have in intensive care units or emergency departments to find what is the right fluid, how much is the right amount. And we use a lot of ultrasounds and echoes these days and do it multiple times, serially over and over again to guide this therapy better. So no matter how well you can titrate it, or extracellular fluid overload or extravascular fluid volume overload is the norm in treatment of dengue fever. Invariably, you are going to cause fluid overload in these children. Said jaisa karoge waisa bharoge. In fact, they are bharoge pehle and bhugatna comes later. You have to fill up earlier and then you have to deal with the consequences later. And we do echo serially. Some reason just it around. But so this was done by a resident of a child who's just recently been admitted. And you can, even for a very untrained eye, you can see that the cardiac function is very poor. The heart is not pumping very well. So myocarditis, again, a very common complication. I wouldn't say very common, but not an unseen complication of dengue fever as well. And if you have other modalities like the icon that we use, you can also look at the extra lung water, intrathoracic extra volume, and all these numbers as well, which help in the management. The vasoactive agents, depending on what type of shock, so they can give you anything, right from a warm shock to a very cold shock to a mixture of all of these in between. So you choose the inotropic agents or the vasoactive agents according to the physiological response that you want. You don't just start with dopamine, then add dopamine, then adrenaline, then noradrenaline. You have to choose what drug you need to get the right effect. So if I need a vasoconstrictor, if I have wide bombing pulses, I would just choose noradrenaline. If the cardiac output is very poor and I need the heart to pump faster or harder, I would do something like adrenaline. So the choice of drug would depend on the physiology that is happening and not on the disease as such. And as I said, you have to pay for what you do. So we do a lot of fluid resuscitation, and all of these fluids will cause overload, and these fluid overloads have to be looked at. And the organ which often gets affected significantly is the lung. So lungs are just like sponge. They are the first to trap water and they're last to push it out. So we have to be careful about overloading the lungs. Every disease, all cases of sepsis will go through these phases of resuscitation, then optimization, and stabilization, and then an evacuation phase, where there will be a stage of spontaneous diuresis or, if needed, induced diuresis or fluid removal. So fluid removal either through the urine or by extracorporeal methods is often essential to maintain the hemodynamics and body functions. So that is known as the de-resuscitation phase. This is equally important as important as resuscitation. So you decide the modality of resuscitation based on the clinical state of the child. Most of the times, once the hemodynamics are reasonably stable enough, diuretics work wonders, and just diuretics will help you get over this overloaded phase. But sometimes you might need more aggressive renal replacement therapies as well. So, Dr. Anil Sachdev from Ganganaram Hospital recently published a study on the predictors of mortality. So, are there anything that can choose or tell us whether there is some predictor of mortality early in the stages of dengue? So, I just wanted to point out this platelets. It's not really a predictor of mortality. We know that. We all chase platelets, but platelets are not really something that matter too much. And in terms of a multivariate logistic regression analysis that they've done, the table on the other side, most of the numbers that you see are very non-specific. So still, as of now, as of today, we don't really have any marker which tells us that this patient is likely to turn worse or do better. Maybe the genomics later on will tell us something, but as of now, as of today, we still have to depend on a clinical judgment to come to that. So just to summarize, dengue is a syndrome, characteristic leaky capillaries, and severe vasoplegia. Fluid management remains the cornerstone of our treatment, and it has to be done judiciously, aggressively, and we have to be ready to face the consequences of that. Some complicated things will require more specialized care. And as of now, there are no real markers of prognostication to tell us which JD would behave in which way. Thank you so much for your time.
Is it on? Yeah, thank you for summarizing so comprehensively the clinical management of a severe dengue. As he rightly summarized about the importance of the hematocrit while judicial the dilemma between the fluid overload and the leaky, which we all have to see. So, is there any criteria for how frequently that hematocrit should be done if we don't have an echo and that possibility to have? Apart from the clinical, is there any set criteria?
It would depend on the severity of the illness. For a child who's very sick, I would probably do it every 6 hours. And a child who's stable for some such children, even once a day might be enough. So if a child who's deteriorated, you will want to do it more frequently. And every child does not need NDQ, does not need ultrasounds. Most of these children, I would say more than 90% of them will still be managed very well in any setup. But we have to be careful or watchful for things that could go wrong and catch them earlier.
Yeah. And another thing you very well highlighted the early role of the colloids, because most of the time in fluid resuscitation we all use crystalloids as the first line of management. So for the colloids, like when it should be actually given, when like the norms, when we should.
Crystalloids are easily available. You should never wait for colloids to come to give a full bolus. So if a child needs bolus, you have a crystalloid with you, give the crystalloid. If the responses are not adequate or the child is in hypotensive shock, you should think of colloid earlier. So you should procure colloid, and something which is very easily and widely available is the 4.5 or 5% albumin, which can be used as a colloid bolus. 20% albumin is not a fluid for resuscitation. It is not a colloid for resuscitation. It should be the 5% albumin. And dextrans are not used in children. They tend to worsen the coagulopathies. So we tend to stick to mostly albumin or FFP.
You know that dengue can affect any age group, and dengue shock syndrome definitely needs to be in hospital. So do you have anything in mind from age perspective that if a child is of this much age, is there a higher chance of dengue shock, or he has so much of comorbidity along with dengue that he must be admitted only because shock can occur faster earlier as a predictor of early admission?
So I'm not aware of any published studies, but we all are aware, at least people like me working in pediatric intensive care units, a young adolescent, a teenager who comes in shock, poor pulses and conscious irritable is the worst subset for us. That somehow, for some reason, that subset seems to be the worst in terms of prognosis. Even this season, the 3 kids that we have lost in our unit have been around 12 to 16 age group, slightly obese, otherwise who come in walking, talking, and they are in shock with very poor pulses. And even with the best of our efforts, they don't seem to do well. And this is not just my observation, this is the observation from my colleagues even across the hospitals in the country.
In younger age, like an infant.
So infants, for some reason, they tend to do better.
So should we reserve it for only the bleeding or non-bleeding?
No, so when you use it as a colloid, it's only to be used as a colloid. It is not to be used for bleeding. If you're using it for a bleeding manifestation, for a deranged coagulopathy, it's a different thing. Then fresh frozen plasma has to be replaced quickly. It has to be given fast. When you're using it as a colloid, you're not in a rush to push all the tetraphed in. You can just use, let's say if you're using 100 ml per hour of fluid, you can maybe use 30–40% of that fluid as a colloid.
So one thing, the ferritin, can ferritin be used as a marker of improvement? Like once we have done it, it could be high.
I think every few years we come up with one marker, we tend to use a lot of it, and then we get wiser. I think this year we are wiser last 2 seasons, we were depending a lot on ferritin. I personally have not found ferritin to be a very good marker. We have had kids with very, very high ferritin doing very well and reasonably lower ferritin worsening rapidly as well. So again, I don't think it's a very good marker. It still remains our clinical sense of involvement.
Next of the questions we can take through the lunch break or breaks. We all are requested to please move to hall A for the formal inauguration, which is right started. So please proceed to hall A.
Would you want Wi-Fi? अरे यार वो देते वाईफाई वाला ढूंढने